Hello and welcome to Pulse Check with Archer Nursing, where nursing comes to life. In this podcast, you give us 15 minutes of your day, and we'll take one complicated nursing topic and make it easy. Ready for nursing to be fun? I'm Morgan, and today we're tackling aortic dissection. As always, let's jump in with our practice question to get things started. A nurse in the ED is assessing a 58-year-old client with a history of uncontrolled hypertension. He reports sudden onset tearing chest pain. He appears pale and diaphoretic, and his blood pressure is 188/92 in the right arm, but 150/78 in the left arm. Which provider prescription should the nurse question? We have A, administer IV esmolol infusion titrated to a heart rate of less than 60. B, prepare the client for an emergent CT angio of the chest. C, initiate nitroprusside infusion to rapidly lower systolic blood pressure to 90. Or D, administer IV morphine for severe pain control. All right, which prescription should you question? Think about it, maybe pin what you think could possibly be the right answer, and we will circle back to that at the end of the episode. But first, we need to get into the anatomy. What is going on with aortic dissection means we have to understand the heart, the aorta, etc. For picturing the aorta, I want you to think of it like a highway. It is a thick, high-pressure tube that launches blood straight out of the left ventricle and distributes it to everything in the body. Your brain, your heart, your kidneys, your gut, your legs, from your head down to your toes, blood is being pumped from the aorta. It is not just like a simple hose, though. It does have 3 layers so that it can withstand that high pressure it needs to have. So innermost layer is called the intima. Think inner, intimate, intima. It is smooth, like a Teflon coated lining that blood can just glide over, non-stick. Next, in the middle, we have the media. So middle, media. It is muscular, it is elastic, so it can stretch and handle that constant pounding of high pressure blood. And then on the outside, the outermost layer is the adventitia. And this is like the tough protective shell that is just keeping everything locked down. And those 3 layers should really work together like reinforced concrete. They are strong, flexible, and they can handle a lot of pressure. So what goes wrong in an aortic dissection? Well, the aorta dissects. That inner lining, the intima, gets a tear. High pressure blood jets through that tear into the middle layer, the media, and starts peeling the layers apart. It's a little like water kind of getting in between wallpaper and the wall. So now instead of just flowing through that aorta, through the intima where it can glide nice and easy, blood starts creating kind of a channel inside that wall because it's cracked open and it's shooting in there. And that creates a disaster for several reasons. As blood dissects down the wall, it can narrow or block off blood flow to major branches of the aorta. And second, the weakened wall is now at risk of rupturing entirely. An aortic rupture is devastating because it dumps all that blood into the pericardial sac, causing a tamponade. See our last episode if you're not sure what a tamponade is. An aortic dissection progressing into an aortic rupture, it's basically not compatible with life if we don't treat it immediately, okay? So first things first, we're going to talk about dissections based on where they are happening. The big one to know is type A, involves the ascending aorta. So you can think A for ascending, and that's the part that comes right out of the heart, kind of at that arch. Type B is lower down in that descending aorta, usually starting after the subclavian artery. What you're really going to worry about is type A. That's the big bad woof that can involve the aortic valve and cause really acute complications if we don't treat it ASAP, incompatible with life. Type B, we hear about left. It can sometimes be managed medically if stable, focusing on blood pressure and heart rate control. So you're not going to hear that talked about as much when we have these like emergency scenario questions. Usually it's going to be type A where we have the aortic arch, that ascending aorta having a tear dissection. So first, who is at risk? How is this developing? It's not like our aorta just all of a sudden tears open. People we are worried about this are often those who have chronic uncontrolled hypertension because we have been running blood through that aorta at really high pressures for years. So it's like beaten down. There's been so much traffic on that highway that over time it starts to cause damage and tear it apart. Another subset worth mentioning, less common, is when there is a connective tissue disorder that makes that aortic wall more susceptible to a dissection because it's weak and stretchy. So that would be something like Marfan syndrome or Ehlers-Danlos. So those are connective tissue disorders. That aorta is weak and stretchy, so it is not as strong of a road. It is easier to tear that road apart. More commonly, we're going to see that uncontrolled hypertension where we've just been pumping that really high pressure blood through that aorta for years, slowly eroding over time. And what symptoms is that going to lead to? Our classic is a sudden severe pain that is described as tearing, ripping, or stabbing. It often radiates to the back between the shoulder blades because that's where the aorta is located. Typically, the onset of the pain is like the worst. It's like boom, it hits you like a brick wall. It's not like with angina where pain kind of builds up. It starts, you're like, oh, my chest kind of hurts, and it gets worse and worse and worse. It's like boom, it hits you all at once, ripping, tearing. That's how your client is typically going to describe it. And because the dissection can track along the length of the aorta, you can see that pain migrate the chest, the back, and the abdomen as it extends if that tear keeps ripping down. At first, blood pressure is going to be sky high because the body's panicking, it's clamping down. If we get a rupture or a tamponade, then the blood pressure is going to drop. You also, a key little tidbit, a little nugget to take away here, might find that the blood pressure is different in different arms. And in like that applies to all of our perfusion things. So pulses, cap refill, skin color, warmth, etc. We might have less perfusion on one side versus the other if a certain branch of that aorta is compromised. So that just depends on exactly where the tear is happening that you could see that symptom. So let's put this together in a case. I'm actually going to tell you a story today of a personal story, not where I was the nurse, but where I was the family member. My grandfather experienced an aortic dissection. It probably was about 10 years ago at this point, but the way that it played out is a great example of what we see and how we need to act. So my grandpa was about 72 when this happens. He was not a super healthy guy, and he had had chronic uncontrolled hypertension for at least a decade, if not longer. We definitely didn't have the best track record and medical care. So, he's not been great about treating this. He calls my dad. My grandpa lives in Florida. My dad lives in North Carolina. And he calls my dad like out of breath, panting, trying to get words out. You can hear the panic in his voice. The words he said, I will never forget. They're etched in my brain. He said, "It feels like someone ripped me in half." My dad's like, "Dad, call 911. Like, I am multiple states away. I can't do anything for you." So he does. He gets off the phone. My dad calls 911. He calls his other brother who is actually closer. And, we get him to the hospital, of course. So he hits the ED room. He is pale, diaphoretic, tachypnic, like panicking. You can tell something is so wrong. That phrase, "it feels like someone ripped me in half," will forever be etched in my memory. You just know something is going on, right? So vitals, this is what was read out to me. Heart rate 112, BP 196, over 98, respers of 26, and he is satting 95%. We popped him on a 2-liter nasal cannula. He's telling the nurses, like, again, "it feels like someone ripped me in half." He's pointing to his chest. And then he's also saying it's kind of between his shoulder blades on his back. Okay. And he's having trouble getting words out. They're like, "How bad is it? Is it radiating?" And he's like clutching his chest and pointing. It's clearly a 10 out of 10 pain. And I will say this man had had multiple prior MIs, and he was not acting like this. He was not in this much pain with an MI. So, switching into my nurse brain, she's doing her assessment, she's listening, blah, 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 as he gets on the monitor and we get all those vitals. The key assessment finding that was charted was a blowing diastolic murmur on the left lower sternal border. All right. Now, all of that like terminology doesn't matter as much, but having that diastolic murmur is really, really important. Okay. That is telling us that we have something going on. And why this makes me think possibly a tear in the aorta is because when that aorta dissects, that inner lining starts to tear, it can distort the aortic valve, preventing that valve from closing all the way during diastole when the heart relaxes. If it doesn't close all the way when the heart's relaxing, blood will leak backwards. So it's that aortic regurg, and that causes the diastolic murmur. So when you put all this together, really the key thing is that tearing chest pain and where it's located, right in his chest, going to his back between his shoulder blades. When you put that together with the massive hypertension, the pale diaphoretic, something is very wrong look, the history of hypertension and the diastolic murmur, aortic dissection should be at the top of your list. So, what are your nursing actions? All right. Immediately, we're getting him on the monitor and we are getting 2 large bore IVs. Okay. We want to put him on a non rebreather to go ahead and maximize oxygen while we get his bearings and then titrate that to keep the SATs above 94. And if I remember right with my granddad, they had put him on 2 liters nasal cannula. He was already at 95%. So they went ahead and just left him there, but it's not uncommon to need a little more support, and a non-rebreather would be a super appropriate choice. We're obviously getting the provider right away. This is an emergency. The provider is going to be focused on ordering the diagnostics. The big 2 nursing priorities is reduce stress on the aorta and emergently get that client ready to go to surgery. What diagnostics is the provider ordering? Likely it's going to be a CT angio of the chest so that we can see if we have a tear. In my granddad's case, they did this very swiftly and confirmed he did have one of those type A tears up in the aortic arch. So, what is the provider ordering to reduce stress on that aorta while we get him to the OR? First thing is usually a beta blocker. That's kind of the star of the show here because it gets the heart rate down, it decreases the force of contraction, and it just slows everything so we have less pressure. So for my granddad, they did IV esmolol, was the beta blocker that they chose. They titrated with a goal of getting his heart down to about 60 beats per minute. And very importantly, the systolic blood pressure of like 100 to 120. We don't want it to drop too much. Let's say we like drop his systolic to 80. And remember, he's like chronically hypertensive and doesn't take his meds. We're going to ruin his perfusion. He's going to be not getting blood to his brain, to his heart. He's going to start acting loopy. So like the 100 to 120 range was honestly very low for his normal, but we had to emergently do that to reduce stress on that aorta. But keep a really close eye on mental status, urine output, like overall perfusion indicators are going to be super important here. It is important to note that you're going to want to start a beta blocker before doing any sort of medication that vasodilates. If you start off with a potent vasodilator like say nitroprusside and you're not slowing the heart down first with a beta blocker, you can cause reflex tachycardia as the BP drops and the body naturally tries to compensate to maintain pressure. And that is going to put even more pressure on the aortic wall that is tearing. So like you could be making things worse, okay? Beta blocker, star of the show. If you're thinking of a med for aortic dissection, that's the one I want you thinking of. The other thing I'll mention is you also want to control pain. That is a huge thing. Feels like somebody's ripping me in half, 10 out of 10, can't talk. That is a problem. And pain drives catecholamine release, which makes hypertension and tachycardia worse. So, IV morphine in small titrated doses as the pain eased, his breathing slowed, he was a little more relaxed. His blood pressure's coming down in tandem with that IV esmolol. And then as that heart rate came down, they did also start a low dose nitroprusside drip to just even more gently nudge down that systolic. But again, very close eye on that number. You don't want to tank it, and you got to keep an eye on those perfusion indicators. Okay, so let's recap. It has only been like 5 minutes since my granddad's made it to the ER, but a lot has happened. We emergently got a CT angio to confirm what was going on there. We're getting ready to bring him to surgery. And as we do, we are trying to reduce pressure on that aorta. We're giving IV esmolol to slower the heart rate, lower that contraction, keep things nice and steady, IV morphine to address the pain, and then an IV vasodilator, the nitroprusside, vasodilate, get that blood pressure down even more. So medical management here is all about reducing that pressure on the aorta so we don't make the tear worse, and then getting him to surgery. Surgery is the obvious definitive treatment here. I feel very lucky to say that he was in the OR in, I think, under 45 minutes from door to OR time. They did not mess around. They were able to repair that tear, and he was discharged, I think, within like 2 weeks. It was a pretty scary emergency that he recovered quite well from, thanks to the nurses and doctors acting very quickly. So, all that to say, let's circle back to our practice question. Let's have you be the nurse. How are you going to act in this emergency scenario? You've got a 58-year-old. They come in with sudden chest pain. It is tearing pain radiating down the back. They have a history of uncontrolled hypertension. They are pale, diaphoretic, and have a BP of 188/92. You've got all the following orders. Which one should you question? A, administer IV esmolol titrated to a heart rate less than 60. B, prepare for an emergent CT angio of the chest. C, initiate nitroprusside to rapidly lower the SBP to 90. Or D, administer IV morphine for severe pain control. Which of those orders should you question? Think back to our story, to our case. What would you do? Would it be A, administering the IV esmolol? That one is good. We don't need to question that. We want that beta blocker. That's our first line. It's going to lower the heart rate, reduce the force of contraction. What about B, taking them for an emergent CT angio? Also appropriate. That's our go-to imaging study. That's like the first thing we're trying to hit so that we know what's going on. What about C, initiating that nitroprusside to rapidly lower systolic blood pressure to 90? That's the one we should question. If you said C, you are absolutely correct. Now, you might be saying, Morgan, we used nitroprusside in our story. We sure did, but only after giving an adequate amount of that IV esmolol, the beta blocker, so that we could reduce that heart rate, prevent rebound tachycardia, and lower that stress on the aorta. If we just rapidly drop that systolic all the way to 90 and his normal was more like, 170, like he was chronically very hypertensive, the body's going to panic. It's going to be like, oh my gosh, pressure's dropping. I need to up my heart rate. We're going to have rebound tachycardia. And we're just going to tank his perfusion. His kidneys aren't going to get blood, so he'll stop making urine. His brain's not going to be getting blood, so he's going to have an altered mental status. So that's really not recommended. Yes, you can use it. It's not incorrect. You shouldn't be questioning the order just because you have a vasodilator, but to rapidly lower systolics to 90 was not appropriate. So question that one. The key takeaway I want you remembering here are the set of symptoms indicative of an aortic dissection and what you as the nurse need to prioritize. So remember that tearing chest pain that might radiate to the back between the shoulder blades as your key symptom of an aortic dissection. Your nursing priority is to recognize it, treat it as a surgical emergency, and protect that aortic wall by controlling the heart rate and blood pressure, and ultimately getting that client to the OR as fast as you can. All right, future nurses, that is a wrap. If you found this pod helpful, I'd love to continue supporting your nursing journey through nursing school, the NCLEX, continuing ed, and beyond. Archer Nursing has you covered with on-demand video lectures, high-yield question banks, live case study reviews, and so much more. We want to help you master tough concepts and make it fun. So join us over at archerreview.com. Follow us on socials at Archer Nursing for more free nursing tips and study resources. Thanks for tuning in to Pulse Check with Archer Nursing. I'm Dr. Morgan Taylor, and I'll see you back next time.